Okay, so our next category of drugs are going to deal with drugs for the eyes and drugs for the ears. So eyes, typically this is for patients who have glaucoma. Glaucoma can either be caused because of an increased aqueous humor in the eye, like an overproduction, or a decreased outflow of aqueous humor. So too much aqueous humor inside the eyeball. It's that stuff that kind of, I guess it's like the jelly inside your eyeball that keeps it inflated. If there's too much inside or not enough is getting out, it's going to cause pressure on your eyeball and can help or can cause vision changes. So think of your eyeball as a beach ball, and there's too much air inside, it's going to be overinflated. Or if not enough air can get out, which an ideal world, there'd be just the right amount of air. But if there's like 102% air inside, then there's going to be changes to the beach ball or changes to the eyesight. So these drugs are trying to either increase the drainage or decrease the production of the aqueous humor inside the eyeball. For all eye drops, one of the nursing implications that you really need to pay attention to is that you do not want the dropper to actually touch the eye. A lot of people will like put it here and then tip back and squirt, but you really don't want to do that. When you're administering eye drops to a patient, ideally they should be laying down, and you can kind of rest your hand. This is going to look funny. You can kind of rest your hand on their forehead and use your other hand to like pull down the lower eyelid and drop the eye drop in there. Make sure it goes in, doesn't like roll down the cheek as a tear. And then if necessary, press on the inner canthus of the eye to prevent systemic absorption, or just to make sure your patient can blink and that the medicine has been absorbed into the eye. So make sure the dropper doesn't touch the eye. And then you'll see in just a second when we talk about this drug to stop systemic absorption. We'll talk about that in just a second. Okay, so you have two different categories of drugs. You have cholinergics and sympathomimetics. Cholinergics are meiotic drugs and sympathomimetics are mydriatics. So meiotic drugs mean that it's going to constrict the pupil. It's going to make the pupil small. Constrict, small. See how meiotics has a C and constricts starts with a C? That's how I want you to remember that. Over here, we have mydriatics, which is going to dilate the pupil. That was a really bad dilation of a pupil. But there is a D in mydriatics, and dilates starts with a D. So constrict, if this is your pupil, constrict is going to make it smaller. Those are meiotics. And dilation, mydriatics, are going to make your pupil bigger. So those are ways that you can remember that. So the cholinergics over here, meiotics, which is going to constrict. This is going to help drain that aqueous humor in the eye. Acetylcholine, this has a quick onset, so it can be used during surgery. And pilocarpine reverses mydriatics, so this can also be used during surgery. But like when you go to the eye doctor and they administer a mydriatic to your eye to dilate your eye so that they can see inside, a lot of nice eye doctors will put pilocarpine in your eye before you leave, so you don't have to wear those big funky sunglasses, and it'll help constrict your pupil and be normal again. Obviously, adverse effects for these eye drops are going to be blurred vision and decreased nighttime vision. So, I mean, that kind of makes sense. They're constricting your pupil, so you could have some blurred vision. We did not have any specific drugs that are mydriatics that dilate your eye, but they do exist. I mean, when you go to the eye doctor and they're checking your eyes, they obviously put something in your eye to dilate it and make it large so they can see inside. But we just didn't have any that we were going to be covering for this test, but do know that they are out there. We're just not studying them right now. Okay, now we have beta adrenergic blockers. The drug here is timolol. Remember, I don't know if we've actually talked about this yet. We're about to. Beta blockers end in lol or OLOL, so either LOL or OLOL. Timolol is going to increase the outflow of the aqueous humor and decrease the formation. So it's hidden soccer punch in both of those things right there that make the beach ball too inflated. Adverse effects of this can include blurred vision, photophobia, and cornea inflammation. And a nursing implication of this drug is that you want to prevent systemic absorption. Since it is a beta blocker or a beta adrenergic blocker, the way that you prevent the systemic absorption is that you press on the inner canthus. This is the inner canthus of the eye. You press here right after the administration of the eye drop, because if it gets to the center, the inner canthus, then it can be systemically absorbed. So you can have your patient either press here, or you can just press there while you're like administering the eye drops. Typically wait like 5 to 10 seconds. Make sure the eye drop has like, I guess, sunk in or whatever you want to say to the eye. It's been absorbed into the eye and hasn't been absorbed into the inner canthus area. Okay, now we have 2 different drugs for ears. I mean, just kind of some nursing implications for these drugs. Ofloxacin. This drug, you're going to want to saturate a cotton ball and then let it just sit in the patient's ear while it's being absorbed. Just kind of let it drip down. And then, how you say this? Carbamide peroxide. This drug is going to help emulsify earwax so that you can so that it can be more easily removed. It's kind of like you have the patient lean over, you squirt this stuff in there, let it sit, and then you'll be able to clean out earwax more easily. It kind of just helps get the earwax out. But when you do administer eardrops to a patient, beforehand, you need to get a baseline hearing assessment just to see where you are, and I guess to see how amazing the patient can hear after they've had earwax removed. And you also need to look for signs and symptoms of an infection. Eardrops are contraindicated in patients who have a perforated eardrum because, I mean, if they have a perforated eardrum and you're putting liquid in there, I mean, that's going to hurt, and you don't want to hurt your patient, and that could exacerbate the problem. So don't do that. For implementation, you do want to clear out the wax first before you administer eardrops. So carbamide peroxide can help with that. And you do massage any eardrops after administration. So you can kind of press, I think it's about right here. You can kind of feel it. Like here is the back of my mandible, right here by my ear. And you can like massage, and like it helps open things up and get things flowing. And then there's 2 different ways that you can administer eardrops depending on the size of your patient. So adults who are taller, you're going to pull the pinna up and back. For children, you would pull the pinna down and back. Just think of that adults are higher up and children are lower down. So for adults, you pull the pinna up and back because they're up higher. For children, you pull the pinna down and back because they are down lower. So those are just some things to help you remember how to administer eardrops. There weren't a ton of things, but I mean, patients do get ear infections, and depending on where the ear infection is, whether it's in the middle ear canal or the external ear canal, the doctor will decide what medicine to administer to them. But yeah, there's information for eyes and ears. So remember, for eyes, you never want the dropper to touch the eye. And for the ear, you obviously need to clean out any wax first. And then depending on your patient's height or size, you either pull up and back or down and back. So there you go. Eyes and ears and